Plain radiography and CT remains the mainstay diagnostic modalities for the assessment of the pleura, and I will be speaking today in the context of these two modalities. First, I'd like to begin with a brief overview of the anatomy at the normal lung and chest wall interface. The visceral and parietal layers of the pleura measure approximately 0.2 to 0.4 millimeters in total thickness and are not visible on CT under normal circumstances. They're surrounded by extrapleural fat of variable thickness, averaging approximately 0.25 millimeters, but can be so prominent in certain patients as to be visible on chest radiographs. External to this is the endothoracic fascia, measuring approximately 0.25 millimeters. It is the last continuous layer within the ribs, and it is also continuous with the periosteum of the ribs and the perichondrium of the costal cartilages. The innermost layer of the intercostal musculature is separated from the more outer layers by fat, vessels, and nerves in the intercostal spaces. Schematically, the visceral and parietal layers of the pleura are surrounded by an extrapleural fat layer of variable thickness. The endothoracic fascia lies over the ribs and is continuous with its periosteum. The innermost intercostal muscle is then interrupted by the ribs and separated from the more outer layers of the musculature by fat, vessels, and nerves in the intercostal spaces. On CT, these structures are represented by a thin soft tissue stripe in the intercostal spaces. The innermost intercostal muscle accounts for the majority of thickness of this density, but it also includes the thickness of the endothoracic fascia, extrapleural fat, and the two layers of the pleura. And because the innermost intercostal muscle is discontinuous over the ribs and also in the paravertebral regions, this soft tissue density is normally also discontinuous over these areas. On CT, the pleura is considered to be thickened when it's visible, or it enhances following contrast administration. And this is best assessed at the paravertebral regions and directly anterior to a lateral rib, where there is absence of the intercostal musculature, more specifically the innermost layer. Here's an example on CT of pleural thickening. Note the smooth thickening and enhancements of the parietal pleura, as well as the visceral layer. And note how the pleura can be visualized directly internal to a rib and also in the paravertebral regions. Some normal structures can mimic pleural thickening, including the transversus thoracis muscle, subcostalis muscle, the intercostal vasculature, and along posterior ribs. Anteriorly, at approximately the level of the heart from the second to the sixth ribs, thin symmetric muscles can be seen just deep to the internal mammary vasculature, and this is a normal structure seen in some patients called the transversus thoracis muscle, and this can sometimes mimic pleural thickening. Posteriorly, at approximately the same level, thin and symmetrical soft muscle strips can also be seen sometimes just inside of the ribs. And this is a normal structure seen in a minority of the patient population called the subcostal muscle. Intercostal vasculature travels along the paravertebral regions and can therefore sometimes mimic pleural thickening, and this can be easily differentiated by looking at contiguous images. And finally, in the posterior ribs, because it assumes a more parallel course to the X-ray beam, sometimes we can see the innermost intercostal muscle traveling over the taper edges of the ribs to insert on the ribs, and therefore sometimes it can be visualized directly internal to the ribs, and therefore mimicking pleural thickening. The normal pleural space contains approximately 1 to 5 cc's of fluid. On a PA view, a blunting of the lateral costophrenic angle requires approximately 250 to 300 cc's of fluid. The lateral radiograph is more sensitive in that approximately 75 cc's will blunt the posterior costophrenic angle. And on the lateral decubitus view, as little as 10 cc's of fluid can be visible, and each 1 centimeter of fluid above the dependent chest wall approximates 200 cc's of fluid. The major clinical differentiation of pleural effusions is a transudate versus an exudate. Transudative fluid collections result from systemic disturbance of the hydrostatic and plasma-oncotic equilibrium. These are usually bilateral, and the most common causes are CHF, cirrhosis, and nephrotic syndrome. Here's an example of a transudative effusion. On the left, there is smooth interlobular septal thickening in this patient with interstitial edema from congestive heart failure. On the right, there are thin crescentic fluid collections layering dependently. And upon placing the patient in a prone position, these flow to the dependent's anterior chest wall. Exudative effusions, in contrast, result from pathologic abnormality of the pleura itself. There's alteration of the capillary permeability of the pleura, or there can be obstruction of the lymphatics. These are more commonly unilateral, have a much wider differential diagnosis, but the most important and common ones are related to infectious and neoplastic causes. Here's an example of an exudative pleural effusion in this patient with a pulmonary emboli. Clinically, transudative and exudative effusions are differentiated based on the Light criteria, which evaluates the fluid based on its contents of protein and LDH, where transudative effusions generally have a lower contents of both. Parapneumatic effusions develop in 3 sequential stages, the first of which is the exudative stage, or the simple parapneumatic effusion. This is followed by the fibrinopurulent stage, or complicated parapneumatic effusion, of which an empyema is a subtype. And finally, the organizing stage, or fibrothorax, or pleural peel. Simple parapneumatic effusions involve thin and uninfected pleural fluid, and these result from inflammation and thickening of the visceral pleura with increased capillary permeability. They demonstrate normal glucose levels and pH levels, and resolve spontaneously with treatment of pneumonia. On CT, simple parapneumatic effusions are small to moderate in size, crescentic in shape, dependent in location, demonstrates no evidence of loculation, may have pleural thickening. On CT, there are bilateral lower lobe consolidations from pneumonia and associated bilateral simple parapneumatic effusions. Note the crescentic configuration, the small sizes, and the absence of loculation and pleural thickening. A complicated parapneumatic effusion results when neutrophils and bacteria accumulate in the pleural space with fibrin deposition. And as a result of the fibrin contents, there is an increasing tendency to loculate. There is often thickening of extrapleural fat and soft tissues. And they typically have decreased pH and glucose levels and an increased pleural LDH. These are commonly drained with tube thoracostomy in addition to antibiotic therapy. Radiologically, complicated parapneumatic effusions are usually lenticular in shape, may be non-dependent, demonstrates loculations, shows the split pleura sign where the enhanced and thickened layers of the pleura are separated by the fluid, can have thickening and increased attenuation of the extrapleural fat because of the inflammatory response. In the right hemithorax, there's an example of a complicated parapneumatic effusion. Note the lenticular configuration with the enhancement and thickening of the parietal and visceral layers of the pleura, the so-called split pleura sign. And there's also expansion and infiltration of the extrapleural fat. And this is in contrast to the simple parapneumatic effusion on the left. Indications for tube drainage of parapneumatic effusions include thick pus upon thoracentesis, positive Graham stain or culture, These are the three which define a collection as an empyema, which is a subtype of complicated parapneumotic effusions. A pH less than 7, a decreased glucose, and an elevated LDH level. A study in 1994 is the most extensive to date, assessing the significance of pleural thickening in determining a fluid collection as exudative or transudative on CT. And it was found in this study that 61% of exudative effusions demonstrate parietal pleural thickening. But of these, all of the empyemas and complicated parapneumotic effusions demonstrate parietal pleural thickening. And in the study, they found that parietal pleural thickening has a 96% specificity for determining a fluid collection as exudative, and a 97% positive predictive value. So the summary from the study is that pleural effusions with pleural thickening are exudative in nature, may be an empyema, but are not transudative. And in contrast, effusions without pleural thickening may be transudative or exudative, but are not empyemas. CT is also valuable for the assessment of complex pleural parenchymal diseases, such as differentiation of a peripheral lung abscess from an empyema. Abscesses generally have thick and irregular walls, are round in configuration, doesn't displace vessels or airways, contains a significant amount of air. They're often relatively clinically asymptomatic and are treated with antimicrobial therapy. These can make acute angles with the chest wall, although this is an inconsistent finding. Empyemas, in contrast, have this smooth walls, as in the split pleura sign, can be lenticular or crescentic in shape, displaces vessels and airways, is ovoid and therefore larger in one projection than the other on chest radiographs, and are treated with tube thoracostomy in addition to antimicrobial therapy. And these tend to make an obtuse angle with the chest wall, although this is also an inconsistent finding. This is an example of an empyema with a lenticular shape, thickening and enhancement of the pleura, and infiltration of the extrapleural fat. The air in the collection is from a recent chest tube placement. Another example of empyemas show the lenticular configuration with thickening and enhancement of the two layers of the pleura, or the split pleura sign, and a non-dependent location for the more lateral collection. And sometimes it can be difficult to distinguish between the two, even when all the factors are considered, such as this case, a large air fluid collection occupying most of the right hemithorax. On the one hand, there's acute angulation with the chest wall, as well as a significant amount of air, which are characteristics of an abscess, although it also demonstrates smooth walls and displacement of the airway, which are characteristics of an empyema. And on surgery, this turned out to be a lung abscess. The final stage of development of parapneumotic effusion is the organized stage, or fibrothorax. And these result when there's fibroblastic ingrowth into the pleural space with organization of the fibrin strands. And these can be seen as early as 2 to 3 weeks following the initial development of the pleural effusion. Most common cause is the tuberculosis. On CT, fibrothorax can demonstrate pleural calcifications, contraction of the involved hemithorax or trapped lung, expansion of the extrapleural fat, and periosteal reaction of adjacent ribs. Here's a radiographic example of a patient with fibrothorax. Note the extensive pleural calcifications, which are displaced away from the ribs by marked expansion of the extrapleural fat, as well as decrease in size of the ipsilateral hemithorax. On CT, again, there is extensive pleural calcification with expansion of the extrapleural tissues. There is also a decrease in size of the ipsilateral hemithorax. At a different level in the same patient, again, there are pleural calcifications shrinkage of the left hemithorax, and infiltration of the extrapleural fat in this patient with extensive destruction of the left lung from tuberculosis. Another patient with tuberculous fibrothorax, there's a chronic pleural fluid collection occupying much of the left hemithorax with extensive pleural calcification, infiltration and expansion of the extrapleural fat, and extensive periosseal reaction of the adjacent ribs from an inflammatory response. Complications of empyemas include formation of bronchopleural fistula or invasion of the chest wall or empyema necessitatis. And these are most commonly secondary to tuberculosis, although other organisms include actinomycosis and nocardiosis. Here's a patient with a loculated pleural fluid collection along the right upper hemithorax with extensive pleural thickening and calcification. And the air fluid level within this pleural cavity suggests formation of a bronchopleural fistula. Another patient who presents initially with an abscess in the left lower lobe. And 1 to 2 weeks following the initial presentation, there's appearance of an air fluid level in the left pleural space. On a radiograph, there is the original abscess cavity and the hydropneumothorax following development of a bronchopleural fistula. And lateral view again demonstrates the original abscess cavity and the hydropneumothorax. CT is valuable for determining the morphology of the bronchopleural fistula. Note the dilated bronchus leading into the abscess cavity, which in turn penetrated the pleural space, penetrated the pleura into the pleural cavity, resulting in an air fluid level. And on the soft tissue images, there is extensive enhancement and thickening of the parietal pleura as a result of the empyema from the bronchopleural fistula formation. Again, we can see the communication between the bronchus into the abscess cavity and finally into the pleural space. Air-containing parapneumatic effusions raise considerations of a bronchopleural fistula, recent thoracentesis or thoracotomy, or rarely gas-forming organisms infecting the pleural space. Another complication of empyemas is invasion of the chest wall. In this case, there is extension of the right empyema into the right chest wall with destruction of ribs along its path. And this is called an empyema necessitatis. Spontaneous pneumothoraces may be primary or secondary, or may be secondary to trauma, such as iatrogenic or blunt and penetrating trauma. Primary spontaneous pneumothoraces generally occur in young males who are tall and thin smokers and results from rupture of an apical subpleural bulla. These are bilateral in 10% of cases and recur in up to half of the patients. Paraseptal emphysema is the most common cause of primary spontaneous pneumothoraces, and central lobular emphysema is also a significant contributor. Secondary spontaneous pneumothoraces generally occur in patients with pre-existing cystic lung disease or conditions that progress to honeycombing, such as emphysema, cystic fibrosis, pneumocystis carinii, Langerhans cell histiocytosis, lymphangioliomyomatosis, metastatic sarcoma such as osteosarcomas, and sarcoidosis or interstitial fibrosis from formation of honeycomb cysts. And traumatic pneumothoraces can arise from iatrogenic causes, including a variety of surgical and interventional radiologic procedures, as well as positive pressure ventilation, and can occur secondary to blunt and penetrating trauma. commonly seen in trauma is a hemothorax, which is defined as pleural fluid with a hematocrit level exceeding 50% of blood hematocrit. Radiologically, these are seen as fluid of high attenuation, or those exceeding 50 of Hounsfield units, a visually radiodense clot, or fluid or hematocrit level. And these can also develop into fibrothoraces. Trauma is the most significant cause of hemothorax, but others include ruptured aortic pathology, ruptured pulmonary arteriovenous malformation, neoplasms, coagulopathy, costal exostosis from shearing of the intercostal vasculature, or catamenial hemothorax associated with endometriosis. Here's an example of a hemothorax with a radiodense clot layering dependently in the right hemithorax with extensive associated fluid of lower attenuation. And this is a patient who had a ruptured pulmonary arteriovenous malformation. Another patient with a hemothorax shows a fluid or hematocrit level with a more radiodense component layering dependently. And this is a patient who had pleural hemorrhage secondary to metastatic disease to the pleura. The manifestations of asbestos-related pleural disease include benign exudative pleural effusion, which is the least common of the manifestations, circumscribed pleural plaques, which are the most common, diffuse pleural thickening, round atelectasis, and mesotheliomas. Benign exudative effusions are the earliest manifestation of asbestos exposure, which can be seen within 10 to 20 years of the initial exposure. It is the least common manifestation, are usually nondescript and self-limiting, and must remain clinically benign for at least 3 years to establish a diagnosis. Circumscribed pleural plaques are the most common of the benign diseases, typically developing after 20 to 40 years of latency. It results from an inflammatory reaction to the fibers when trapped in the parietal pleural lymphatics. They may involve the visceral pleura, as some of them can be seen in the fissures. There's no known malignant potential. And the severity of pleural plaques increases with the duration and intensity of dust exposure. Radiologic findings of circumscribed pleural plaques include an elevated and sharp margin against the adjacent lung. These are most commonly located in the posterior lateral pleural surfaces, in the paravertebral regions, and along the dome of the hemidiaphragms. Characteristically, these spare the pulmonary apices and costophrenic sulci, are usually bilateral but asymmetric, often favoring the left. 10 to 15% of the plaques are calcified. Radiographically, these manifest as amorphous and geometrically shaped densities, especially when seen on FOSS. And on CT, these are seen as smooth elevations of the pleural surface with smooth marginations against the adjacent lung. A common location for pleural plaques are the posterior costophrenic surfaces, as well as the dome of the diaphragm. And these characteristics spare the costophrenic sulci. Diffuse pleural thickening arise from fibrosis of the parietal and visceral layers of the pleura in contrast to circumscribed pleural plaques. Some of the suggested mechanisms include a prior benign pleural effusion, confluence of focal plaques, or extension of the parenchymal fibrosis associated with asbestosis. And also, in contrast to pleural plaques, they will involve the costophrenic sulci and may also impair pulmonary function. CT example of diffuse pleural thickening. Note the extensive and confluent thickening of the pleura with involvement of the posterior and lateral costophrenic sulci. And again, at a different level, thickening at the posterior and lateral costophrenic sulci with the focus of pleural calcification consistent with asbestos exposure. Round atelectasis are round or wedge-shaped peripheral masses which arise from asbestos-induced pleural fibrosis or result from compression and distortion by a pre-existing pleural effusion. Radiologic findings of round atelectasis must meet a strict diagnostic criteria, and a biopsy is usually warranted if not all are met. And these include an associated pleural disease, extensive pleural contact, swirling of bronchovascular structures into the mass, as in the comet tail sign, or volume loss of the affected lobe. And if all of these criteria are met, surveillance will be an appropriate management option, and if not, a biopsy is usually warranted. An example of round atelectasis shows extensive pleural disease in the thickening and calcification, extensive pleural contact, and swirling bronchovascular structures entering the mass or the comet tail sign. Another example of round atelectasis shows the swirling bronchovascular structures entering the mass associated with extensive pleural disease. Malignant mesotheliomas account for less than 5% of pleural malignancies, and these are not dose-related, and therefore are frequently identified with no evidence of pleural plaques or parenchymal fibrosis. And these typically develop following a 20 to 30-year latency period. 80% of these are related to prior asbestos exposure. Radiologic findings of malignant mesothelioma is often nonspecific because they can be diffuse or focal and therefore difficult to distinguish from processes such as pleural metastases. But most commonly, these present as unilateral pleural thickening, which is sometimes extensive enough to encase the entire lung. These extend into the major fissure in approximately 44% of the times, and minor fissure in 16%. Less common manifestations are multiple masses or a solitary mass. These are associated with a unilateral pleural effusion in 80% of cases, calcification in 10%, and this may result from either absorption of an adjacent calcified pleural plaque or an osteosarcomatous histology. And they can also invade the adjacent chest wall. Here's an example of malignant mesothelioma with extensive and nodular thickening of the pleura encasing the left lung, with extension into the left major fissure, and a calcified pleural plaque indicating prior asbestos exposure. Different manifestation of malignant mesothelioma, a focal mass invading the chest wall and destroying the rib in its path. And another example with multiple focal masses in the right hemithorax with calcifications arising from an osteosarcomatous component. Liang et al. Did a study evaluating for the significance of CT for determining a pleural thickening as malignant, and they focused on 4 particular features: circumferential, nodular, and mediastinal pleural thickening, and parietal pleural thickening exceeding 1 centimeter. And all of these 4 features were found to have very high specificity for indication of a malignant pleural thickening, and most notably circumferential pleural thickening, which has 100% specificity. And taken together, these have an overall accuracy of 75%. Some examples of malignant pleural thickening. This is a patient with mesothelioma. Note the nodular, circumferential, and mediastinal pleural thickening. And this is a patient with pleural metastases, again showing nodular and circumferential pleural thickening. Another patient with multiple nodular pleural thickening and a large pleural effusion with parietal pleural thickening exceeding 1 centimeter. Malignant pleural effusions, when unilateral, are mostly from pulmonary arterial tumor emboli seeing the pleura, such as from a lung primary. And bilateral malignant pleural effusions usually arise from hematogenous seeding after first metastasizing to the liver. Lung, breast, and lymphoma account for the majority of malignant pleural effusions. Some clinical methods for diagnosis of malignant pleural effusions include pleural fluid cytology following thoracentesis and pleural biopsy for a combined yield of approximately 75%. The most common primaries giving rise to pleural metastases include from the lung, or particularly adenocarcinomas, breast carcinoma, gastrointestinal tract, renal cell carcinoma, and ovarian primary, and thymomas. Here's a patient with a large malignant right pleural effusion and an enhancing right pleural nodule from metastatic renal cell carcinoma. And another patient with multiple enhancing pleural nodules and a large right pleural effusion in a patient with a colonic primary. And this patient has multiple pleural masses, studying the pleura on the CT. And this is from a bronchogenic carcinoma primary. This is a patient with an anterior mediastinal mass, heterogeneous in attenuation, which was found to be an invasive thymoma associated with a small left pleural effusion. And on a follow-up CT following median sternotomy and thymectomy, multiple pleural masses and nodules are found, including the left major fissure. And this is from an invasive thymoma. Pleural implants in thymomas are associated with the 30% of thymomas which are invasive. These are often unilateral and are usually not associated with pleural effusions or large pleural effusions. Localized fibrous tumor of the pleura used to be called benign mesothelioma, which is an obsolete term. These are not associated with asbestos or tobacco. Up to 13% of these can be malignant, which is why a localized fibrous tumor is a better term than a benign fibrous tumor. And 50% recur locally following resection. These arise from the visceral pleura in 75% of the cases. Some classic associations include hypertrophic osteoarthropathy in 30% and symptomatic hypoglycemia from proliferation of insulin-like growth factors. Radiologic findings of localized fibrous tumors include a well-defined juxtapleural mass, which can vary in size from a small nodule to massive. 50% of these are pedunculated, and when they are usually benign. They typically demonstrate heterogeneous enhancements. Pleural effusions and calcifications are disproportionately rare. And when they exceed 10 centimeters in size, they are more likely to be malignant. Here's an example of a localized fibrous tumor of the pleura occupying most of the right hemithorax. Note the heterogeneous contrast enhancement of this mass. Another example of a localized fibrous tumor of the pleura with a well-circumscribed mass located within the left major fissure. Pleural lymphomas accounts for approximately 10% of malignant pleural effusions, and these are typically exudative effusions arising from impaired lymphatic drainage, obstruction of the thoracic duct giving rise to chylothoraces, or direct involvement of the pleura by lymphoma. And these are typically seen as plaque-like masses or thickening. This is a patient with Waldenstrom's macroglobulinemia with extensive thickening and contrast enhancements of the pleura with an associated pleural effusion. And this is a case of pleural lymphoma. Thank you.